I would like to introduce Dr. Taylor and have him enlighten you.
My patients are so well educated, they have very few questions. I want to thank you all for coming to our presentation tonight. I'm going to be talking a little bit about how prostate cancer is diagnosed, some statistics about success rates, how we do surgery for prostate cancer. We also have Linda Adams in the corner over here. We have a incontinence center at Pacific Urology. So if any men or women here have any issues with bladder control, bladder issues, difficulty urinating, she is our go-to person. She figures out exactly what's causing your symptoms and what we can do to fix it. So she's a wonderful resource and a wonderful person. And if you have any questions, she's right over at the table over there. Now, prostate cancer is the commonest cancer in men. It's the second leading cause of cancer deaths in men, second to lung cancer in death rate. As most of you know, prostate cancer grows very slowly, but some are not those slow growers. They can grow more rapidly and be more dangerous. Now, if prostate cancer is detected early, most of those are detected at potentially curable stages. If the cancer is caught when it's still confined to the prostate gland itself or immediate region of the prostate, it is still potentially curable. However, once it spreads out of the immediate vicinity of the prostate, it's not curable. It's treatable. We can keep it under control for many years, but it's not curable once it's spread to other places. I don't know if I have a pointer up here. Do you have a pointer? No? So this is a picture of the bladder, and the prostate gland, as you can see, sits right under the bladder. And the urethra, the channel that you urinate through, travels directly through the middle of the prostate gland. The prostate itself is the gland that makes the fluid that the sperm swim in. That's its job. And how is prostate cancer detected? Well, digital rectal exam is a test that should be performed by your primary care physician or urologist. I'm just going to go back to that last slide. You can see where the rectum is, and if we put our finger in the rectum to feel the prostate, we can only feel the back part of it. We can't feel 80% of the prostate gland. So a digital rectal exam at best can only detect maybe 20% of the cancers. The others are on the other side or just in a location where we can't feel it, or if it gets very big from the other side, maybe we can feel it, but then we haven't caught it early. So in the late 80s, early 90s, PSA became popular and of widespread use. PSA stands for prostate-specific antigen. It's an enzyme that's only made by the prostate gland and prostate cancer cells. It's not made by any other organ in the body. And they developed a normal range of 0 to 4, although some people use other numbers for the upper limit of normal. But we know when the PSA is between 4 and 10, and the urologist takes a biopsy, we find cancer about 30% of the time. If the PSA is over 10, we find it over 50% of the time. But even if it's 0 to 0.5, and if a biopsy is done, we find cancer 6% of the time. And you can see the other numbers between 0.5 and 2 at 16%, and between 2 and 4 it's 20%. So PSA is really a continuum. It's just a probability statement that if you have a biopsy, what are the odds that you would find cancer there? There isn't a number below which we haven't found prostate cancer.
That doesn't distinguish between slow-growing and aggressive? Or?
That's absolutely correct. The question was, does it distinguish between a slow-growing or a fast-growing cancer? The answer is no. we have other ways of doing that. We look at what's called the PSA doubling time, how long it takes to go from 2 to 4 to 8 to 16. So we've been looking for tests that are better than PSA, since it's just a continuum. And these are just a few. There will be a quiz on the end, so I expect you to memorize all this. The PCA3 is a test that some of us use. It involves doing a rectal exam with a prostate massage, which most men do not like. And then they urinate afterwards, and we send that fluid to a lab, and they check for this antigen. And it's supposed to be about 60% accurate, which isn't a great number, but it sometimes helps. There's a new test called the PHI test, which stands for Prostate Health Index, and it's that complicated formula that you see there. It is commercially available, but not in widespread use, and it's supposed to be more accurate than the PSA all by itself. So if someone is wondering, do they need a biopsy or do they need a second biopsy, sometimes we order this test, and it can help someone to decide if they want to go through it again. And there's this tumor suppression assay with the PCA3 and the 4K score, which is a combination of PSA, free PSA, intact PSA, and kallikrein-related peptidase 2. So these are all new tests. You may hear something about them in the future. They may eventually replace PSA all by itself as a screening tool, but they're not in widespread use at this time. Now, how do we establish the diagnosis of prostate cancer? It's with a biopsy. And most men here know how a biopsy is done. We take an ultrasound probe shaped like my finger, slide it in the rectum, inject some Novocaine in the prostate to make it go numb. And then you take some biopsies, and we have this little needle that darts in and out of the prostate in the blink of an eye. You may hear a click, you may feel a vibration, but it shouldn't be painful. And the standard is to do 12 different samples, kind of evenly spaced through the prostate. And that's the standard method of doing a biopsy. In 2014, Medicare decided it'll only pay for 9 samples instead of 12. Is there any medical rationale for that? No. They just decided they'll only pay for 9. And the latest thing is to do what's called an MRI ultrasound fusion-guided biopsy. Lately, well, let me back up. We've been using MRI to try and image the prostate for years, but we didn't know what prostate cancer looked like on MRI. Does everybody know what an MRI is? Magnetic resonance imaging. Orthopedists use it a lot to look at spines and joints and other things. So we've been looking at the prostate with MRI, and we just didn't know what prostate cancer looked like. Until the past about 8 months or so, we figured out what prostate cancer looks like, and we do what's called multi-parametric analysis. We look at multiple parameters, and if all 3 of these parameters line up, if we take a biopsy, we find cancer quite often, so we now know what it looks like. And we can take that MRI image and move it onto our ultrasound screen, fuse it onto our ultrasound image in real time as we scan through your prostate, and then direct biopsies directly into the area of concern that we see on the MRI. So this is the latest thing that we're doing. It improves our cancer detection rate on patients who've had previous negative biopsies. However, most insurances aren't covering it yet as the first test. They want a negative biopsy first. If you have a negative biopsy, then they'll pay for the MRI, ultrasound fusion-guided biopsy. I think it's just because it's so early in this new technology. I predict in a few years they'll insist on an MRI before we do a biopsy. And the reason is, if an MRI is absolutely negative, we're at the 90% confidence level that there's no cancer. So that would mean you don't even need a biopsy. So it would save men a lot of unnecessary biopsies. So that's one of the new faces in prostate cancer. If the pathologist does find cancer, he assigns it a score called the Gleason score. The scale goes from 2 to 10. For all intents and purposes, the scale goes from 6 to 10. If they see one cancer cell, it's a 6. So the scale really goes from 6 to 10. 6s are the slowest growing type. They tend to grow locally. They don't tend to spread to other places. 7s are a little more dangerous. Now they have cells that can get into the bloodstream and spread. 8, 9s, and 10s are much, much more dangerous. These can spread early and are the hardest ones to cure. So if you have prostate cancer, there are lots of options for treatment. Option number 1 is called active surveillance. That's, if you don't mind the double negative, not doing nothing. It's active. We do serial PSAs. We do serial rectal exams. We repeat biopsies periodically. And now we're doing MRIs. So we're actively monitoring these patients. Who are the best candidates for just monitoring this? Gleason 6 or less. They have to have minimal disease, low volume cancer. They have to be asymptomatic, no symptoms of any kind. And the theory behind this is some of these slow-growing cancers grow so slowly that a man will lead his normal lifespan and die of old age of something else and never have needed treatment for it. And the patient gets to keep and enjoy his prostate during all those years. The other issue is if we think it is progressing, we would still be able to intervene and effect a cure before it spreads somewhere else. So that's why we have to keep a very close eye on those patients. When we've looked at our practice, we have about 20% of our patients on active surveillance. So it's a very common form of treatment these days. Now it does have some disadvantages. You may wait too long and miss the opportunity to cure it. It may spread before you got there. There's also morbidity associated with repeat biopsies, PSAs, the anxiety of knowing you have a cancer there and wondering if you're doing the right thing by not treating it. So there are some disadvantages to active surveillance. It's not for everybody. Of the treatment options, there are several good treatment options. And the problems that a lot of our patients face is that the treatment options now are so good, it's hard to choose between several good options. It's not that there are any bad options anymore. The thing that urologists are doing is called a robotic laparoscopic radical prostatectomy, where we take the prostate out in its entirety. Sometimes we still do an open surgery for this with an incision, but that's relatively uncommon now. And there are risks associated with taking out the entire prostate. There's a risk of incontinence. It should be less than 5%. As our techniques get better and better and better, our incontinence rate is getting very, very low now. In my hands, it's probably less than 2% now. But if we do have incontinence, it can be, of course, fixed. Do you remember Robert Goulet? Are any of you old enough to remember? Yeah, when he had prostate cancer, he said he'd much rather wear a diaper than a shroud. Fortunately, nowadays, you don't have to choose between either of those. It's very rare for the patient to be incontinent nowadays. And the other risk is impotence. The nerves for erection travel very close to the prostate. The closer to the edge of the prostate we stay in our surgery, the more likely we are to save the nerves for erection. The farther away we go, the wider we go around the prostate, the more likely we are to cure it. But you could leave cancer cells behind if cancer grows along those nerves. So impotence can be as low as 10% or as high as 100% following the procedure. One of the advantages of taking out the prostate is called accurate pathologic staging. Before the surgery, we do some scans, we check your bones, we make sure it hasn't spread anywhere else by these x-ray measures. But once you have the prostate out, you know its exact Gleason score, you know its exact extent. Was it confined to the prostate? Was it creeping out? Did it spread to regional lymph nodes? So we have all of this accurate pathologic staging. That allows us to make predictions on whether or not you're likely to recur. We know how closely to watch you. We can give you additional treatment if we think it's needed. So it has that advantage. If you do have one of the two complications of incontinence or impotence, those both can be fixed nowadays. You don't have to live with either one of those. When we do these robotic prostatectomies, it's just one night in the hospital. Most patients are home the next day. They go home with a catheter for about a week, and then they're off and running on their own. Monitoring people after the prostate out is very simple. All you need is a PSA. The PSA will rise on average 8 years before you would detect it on any scan or any other method. The PSA is that sensitive nowadays. So all we need to do are PSAs afterwards, and that tells us how you're doing. And one last advantage, if we do think you're at high risk for a recurrence, or we detect that it has recurred in the bed where the prostate used to be, we can always give you radiation treatment at that point, and that salvages the situation, and you still have a chance of being cured. This is just a diagram of what the room looks like when we do a robotic prostatectomy. The patient is under those drapes. The surgeon is actually sitting at that console to the left. I'm not even at the patient's side. We have a nurse at the patient's side and an anesthesiologist. And the robot does all the work. You can see there are various different little hands off to the right there with different instruments, with different things that we want to do. So this is the console. So I sit at the console, my hands are in these little things, and whatever I'm doing with my hands, the little robotic hands do. And they're more precise, more delicate than my own hands. What that translates into is, when it comes to reconnecting things, it's much more precise, much more delicate. Men regain their bladder control night and day quicker. They have catheters for a shorter period of time. Their erections come back quicker. Men don't need blood transfusions anymore. It's just a much more rapid recuperation. And this is what a patient's abdomen looks like afterwards. You can't even tell that they've had an operation because the instruments go through just little punctures in the skin. If you look at his belly button very closely, you can see a little tiny scar because we take the prostate out through the belly button. Now this is the survival rate from Baylor College in the early 2000s. And on the left axis is the probability of being cancer-free, and on the bottom line are the years after the operation. And if the cancer was confined to the prostate and they had a low Gleason score, the cancer control rate, you can see, is like 96%, so it's really very good. The second line down, ECE, stands for extracapsular extension. That means the cancer was just creeping out of the capsule of the prostate at the time it was removed. So they do well, but about 70-75% are still cancer-free at 10 years. SVI is the next line down. That stands for seminal vesicle invasion. That means the cancer was growing into a structure outside the prostate gland itself. So that has a much worse prognosis. They're much more likely to recur. And LN positive means lymph nodes were positive, means the cancer spread to the lymph nodes. And you can see that much worse prognosis. So these numbers are from the around 2000, when the lower limit of PSA was 0.4, which is not very sensitive. Our assays now are 40 times more sensitive. They go down to 0.01. So I think if we did the same graph today, all those curves would be lower down, because we can detect minute amounts of cancer that they couldn't detect back in the